Good afternoon, everyone. Welcome to today's webinar hosted by Patagonia Health. Today's webinar topic is on increasing immunization health equity. If you aren't familiar with the Zoom webinar platform, take a look at the control panel at the bottom of your screen. Here you can configure your audio settings, send chat messages, and ask questions. Just as an introduction to see if that chat function is working, go ahead and say hello and tell us what state you are joining from. As a quick background about our speaker today, Rachel Bartmans got her start working in vaccine equity, where she was helping to develop the new vaccines for children strategy. This project was centered on applying COVID-19 lessons learned to the vaccines for children space in North Carolina. In her current position, she is one of 7 immunization consultants and covers the western region of the state. Rachel is a 2025 HPVRT Emerging Leaders Fellow through the American Cancer Society. In her spare time, Rachel volunteers with the North Carolina Immunization Coalition and the Community Care Clinic of Forsyth County. All right, Rachel, we are so excited to hear from you, and you can go over and start sharing your screen.
Awesome. You should be able to see my screen.
Yes, we're good.
Fantastic. Thank you, everybody, for joining us today. I'm really excited to share all about the intersection between health equity and quality improvement. I see we have lots of people joining us from lots and lots of states. Special call out to my home state of Michigan and all of my fellow North Carolinians here. I'm going to go ahead and jump right in though. As Dana said, my name is Rachel Bartmans. I am a regional immunization for the state of North Carolina, and we are here to talk today about utilizing quality improvement methods to address immunization health equity. So part of my job is to go to different providers' offices who are enrolled in the Vaccines for Children program, also known as VFC, do the immunization quality improvement for provider visits or EQUIP visits. This program is really set up by the CDC to help manage that provider level quality improvement. During these visits, we discuss things like workflow, reports for recall and tracking, utilizing the state's IIS, and some other immunization-related items to help identify opportunities where that particular office or health department could help increase vaccine uptake and decrease vaccine hesitancy. So as a part of this program, the CDC has 4 predefined strategies, and these include facilitating return for vaccination, leverage IIS functionality, give strong vaccine recommendations, and not strengthening vaccine communication. And I don't know that I'll be able to see it with the way my screen is set up right now, but give me a good thumbs up, raise your hand, something like that if you're already involved in the VFC program. I guess I can't really see it. Never mind. So with that, the strategies have some possible action items that include recalling for those missed appointments. So basically making sure that if a parent misses their kid's scheduled well-child visit or immunization appointment, that they get a phone call within the first 3 to 5 days, ideally the same day. Scheduling that next appointment at checkout so those kids are not left to follow up. And then in using our IIS, measuring your coverage levels. So looking at where your immunization rates are on a consistent basis, activating patients. So in North Carolina's registry, you can manage whether that patient is actually associated with your practice or not, and then establishing a reminder process for those scheduled appointments. Other action items, this Give Strong vaccine recommendation one is really associated with HPV, giving that presumptive recommendation same way, same day, every time a kid is due for vaccines, and then recommending that HPV shot at age 9. And the last predetermined strategy is that vaccine communication strategy that has to do with vaccine policies, vaccination education materials, and clinic materials, and things like that. In North Carolina, we looked at strategies and we looked at our population and realized that this really wasn't enough for the people we were seeing in our doctor's offices. We really needed to fill those gaps for underserved populations and the needs that may not be met within a normal provider. So from there, we started to look at the vaccine disparities in North Carolina. We looked at COVID-19 coverage from August of 2021 to March of 2022. And there we can see some dramatic differences in booster vaccination status based on race and ethnicity of the patient, where your Asian Pacific Islander patients had the highest vaccination rates, and other multiple races had the lowest vaccination rates. We can also look at that from the other side of the coin, considering vaccine hesitancy for COVID-19. The one major trend we can see here that stands out really quickly is that your Raleigh, Durham, Charlotte areas have a lot lower vaccine hesitancy than some of those more rural areas in North Carolina. So these are all things we really took into account when we started to develop new equity strategies. After looking at those overall trends, we really wanted to see if this applied to childhood immunizations as well. So using that CDC Vax view and pulling back-end data from our immunization registry, we were able to see that 24 months, we can see there is a pretty significant difference between those race and ethnicities when looking at vaccination coverage for that 7 series, where your white non-Hispanic population has the highest vaccine uptake. This actually does a pretty big 180 when we look at 13 to 17-year-olds for HPV, where for 1 and 2 doses are up to date for HPV, their multiple race non-Hispanic population has the highest vaccine uptake. So using all of this information and a compilation of the lessons learned from COVID vaccination implementation, some literature reviews of existing strategies, and vaccination coverage reports at the county level, we started to really develop this IQIP strategy that would be added on as a 5th option for providers during IQIP visits. And one of those really big things we wanted to look at here was making sure the strategy was driven by data within the state and was able to engage those low vaccination populations. Before we really jump into the strategy, I want to show you higher level. In the US, we see similar trends in immunization when we look at those same 2 age groups at the national level. Vaccination coverage continues to vary by race and ethnicity. We do see some changes when looking at that country level data, especially for HPV, where the Hispanic population has the highest uptake for 1 dose, and is tied for update with other multiple races, non-Hispanic, when we look at the update rate. So let's jump into the strategy, how you can address health disparities in immunization coverage. We came up with this list of possible action items to give providers a jumping point when we start talking about strategy. I'm going to run through these really quickly here, and then we're going to dive into each of them a little bit more deeply. The first piece being educating staff on health equity and how this relates to immunization coverage. Second action item is collecting and recording race and ethnicity of patients in the IIS to improve tracking and implementation. Then we have exploring barriers to immunization and providing resources, with that ensuring that these resources represent the patient population you serve. And in order to expand those resources, working with community partners, including the local health department, to recruit those unvaccinated or under-vaccinated populations. And then finally, on a broader level, having an inclusive workforce that's representative of the patient population that you're serving. The first action item is to implement first action item for implementing any sort of equity strategy in your office. It's to do some education and level setting, making sure everyone understands what equity is, how it relates to immunization and healthcare overall, and then beginning to look at the gaps within your system and how they can be mitigated. One thing I really talk about regularly when I'm in a provider's office is transportation issues. If a provider has transportation issues, they're not going to make it to their appointment. They're definitely not going to be up to date on immunizations, well child visits, things like that. So knowing these patients and knowing where we may need to supply the Medicaid transportation phone number or provide resources on what public transportation is available, if that's an option. And then starting to discuss with patients when they are canceling their appointments or you're calling after they miss their appointment and asking that why. Start to remove those barriers to patient care. Following that, considering accessibility in the office. Can our patients make it in the door? The number of days I walk up to a clinic with a cooler full of vaccines in a 100-year-old building with one of those 100-pound doors and go, there's no way for me to open this door. So, how are your patients physically getting into the building and is it accessible for them? And then we can't talk about gaps in the system without talking about food insecurity. Patients are really going to be concerned with meeting those basic needs before they start to consider their medical needs, at least until they become very serious. So how can we help address that while patients are actually in the office? And we'll talk about this a little bit more when we talk about partnerships later on here. The last major thing we want to consider is language. Not only what language are your patients speaking, but also health literacy levels. They need to be able to understand what you're talking about. So, in this case, consider, do you have an interpreter in the office? Do you have the option to have a virtual interpreter, a phone service, something like that? We really don't want, say, a child interpreting for them their own appointment to their parents. That kid's not going home with any immunizations if that's the case. They're not going to want to get stabbed for a shot. They're going to tell mom they're not due for anything that day. Then on the other side of that, making sure staff are educated on that health literacy level. So not using abbreviations and breaking information down into simple terms that patients can understand. In addition to discussing those health equity principles with staff, we really want to ensure that the correct race and ethnicity are collected for each patient. There's really three main options when we're talking about this. To ensure that we have this really important piece of information from each patient, and we want to make sure we're collecting it from the patient self-reporting and not staff observation. First option is to ask at the appointment check-in paperwork, somewhere written, either in your portal check-in, something like that. The second option is for the person checking the patient for the appointment, verbally confirm that race and ethnicity. Or your third option is for this information to be confirmed during patient rooming or when the clinical staff are bringing the patient back into the actual clinic. And we really want this to guide equity discussions and challenges for specific subpopulations that are seen in your office. When you have this information, your office can really focus efforts on unvaccinated populations and effectively target your resources, knowing who you're seeing. And in a preparedness situation, North Carolina in particular can pull some back-end registry data to look at exemptions and target those low uptake groups and really effectively use the really limited money we have in public health overall. So a big piece of health equity, we talk about all these other things, but it's really making sure that we're taking care of that whole patient and not just getting shots in arms. Acknowledging that all of these are really moving pieces that are tied together in one way or another. The way to do this is look at the barriers and provide resources. This is done through a social determinants of health screening or needs assessment, depending on what you want to call it, while patients are in the office for every visit. So not just on a yearly well child visit, not just when you see that kid once every 3 years when they need a sports physical, but every time they're in the office. Generally, these screenings look at food insecurity, housing insecurity, interpersonal violence, sometimes bill pay, things like that. Short 5 to 10 question surveys. And this can either be done verbally or written. If you're going to do written, be aware of the reading level and any language barriers that may exist for your patients. If you're going to do them verbally, be aware that some patients may be more sensitive to sharing this information verbally than written. But that being said, you all are the providers. You know your patients. Be flexible and adjust as needed. Once patients complete this, the second step is really the important piece of actually doing something with this information. It's all fine and dandy if you do this screening and say, yep, that patient has food insecurity, throw it in a folder and call it a day. That's not really helpful for you. That's not really helpful for the patient. So the second step of this is a really great spot to pull in those community partners and organizations in your area. Most counties have some kind of community resource guide. I recommend printing this, sharing it with your office, post it in your Teams channel. Generally, these are multiple page packets that have housing resources, food resources, clothing banks, bill pay, dental, all of that good stuff that if a patient comes in and needs something, you have that information. So when a patient is flagged for one of those questions on that social determinant screening, you can either send them home with contact information or an address, or assist yourself in getting that contacting to get that need met. For example, if a patient has housing insecurity, you could share that number for bill pay assistance in the area, or a church that has some assistance to help people in the community pay their bills. And then, in addition to making sure we're filling our patients' needs, we really want to ensure that all of these resources and information that we're giving the patients is understandable to them. So consider the reading level of your patients, language barrier, health literacy level. If you're going to develop your own educational materials in the clinic, about how you can incorporate the use of pictures instead of or in addition to words to really help patients succeed in understanding the healthcare information you're providing. Another big piece of this is consider technology access. In our day and age of smartphones, that may not be the case for every patient. So ensure you have an easy way for patients to schedule an appointment with your office that's not online. Maybe not through 400 clicks on a phone tree before they get to talk to someone to make that appointment. And along that same line, make sure they can confirm their appointment over the phone if they don't have access to MyChart or internet regularly. When we look at the graph on the left, this is where we pull in that health literacy level. We can see that 26% of adults in the US either have basic or below basic health literacy level. And when this is broken down by age, we see a really huge disparity in that 65 plus age group, where 29% of individuals have a below basic health literacy level, and 59% of them have a below basic or basic health literacy level. And that is not an insignificant number of patients that are going to be seen in your office, especially if you're seeing a lot of family medicine, things like that. One way to make sure all patients are understanding the information that's being shared is to use that question response method. So you go through, explain how to use the insulin pump, and then have the patient go back through and explain and demonstrate what they're going to do when they are not in the office. That way you can confirm that there aren't any gaps in that education before they walk out of your exam rooms. Bringing back what we talked about in previous slides, this might be my favorite part of health equity, is really engaging the community partnerships. There are already people in your community that are the boots on the ground, have the resources, have the trust with the underserved populations, and know what's really needed. So work with them, touch base with them, have a contact person there. One of my favorite things to suggest when talking about this is to work with a local food bank, whether it be a church, nonprofit in the community that already has those non-perishables. See if you can't get a bag in the office. That way, when you have a patient that is flagged for food insecurity, you already have those non-perishables. You can send them home with that bag and fill that gap today. Ideally, you'd also include a phone number, contact information for someone at the food bank that can continue to fill those needs. And maybe you can return that favor by the office hosting a food drive or something along those lines. So that relationship is really mutually beneficial. And in filling that patient gap while they're there, ideally it's going to increase their return rate and decrease those no-shows because they know they're going to get that need met while they're actually in the office. It'll be really helpful for your patients to start building these overall relationships with churches, nonprofits, local businesses. These organizations are truly able to help your patients directly and indirectly. And it helps to build that trust within the community and engaging those community partners. Be aware of all of this and have information in your office on other services that might be beneficial for your patients. That bill pay assistance, like I mentioned, If you're a pediatric provider, where parents could go to get state supplied or low cost immunizations, how to enroll in Medicaid, resources that come along with that. Things like that may also be helpful for them to know if you are already their trusted medical home. So, using these community partnerships, you can really also work together with those organizations that already have the trust within the community, help recruit unvaccinated individuals. So, this could be being involved in school events, parades, festivals, farmers markets, health fairs, anything like that to help you really understand where the gaps are and put a name to a face for the individuals in your community and start to build that trust. The really important piece here, though, is to show up consistently. Don't be that office that shows up once, makes all sorts of promises, disappears in the wind, never to be seen again. That's going to do more harm than good at that point. Along with these in-person events, this is also a great spot to start getting some traction on social media. Social media is a really great spot that you as the trusted messengers can share some vaccine information, equity resource information for patients in the community. We really want to focus on those individuals who are vaccine hesitant or also known as the movable middle. The really important piece here is making sure you're sharing facts and cited information in languages that individuals that are reviewing it can understand. So not in medical professional language. And in these instances, we really don't need to reinvent the wheel either. CDC, American Cancer Society, numerous provider organizations, nonprofits, all have pre-made social media graphics having to do with vaccines, equity, resources, everything like that. They're generally willing to share. Feel free to use what already exists. We don't need to all be doing the same work in the same space and doing it slightly differently. The final action item we selected in this strategy really has to do with broader picture for each clinic. Being mindful that there's an inclusive workforce that's representative of the patient population you're serving is really important. You're more likely to trust a healthcare professional who looks like you, talks like you, has the same beliefs as you. This helps to reduce those language barriers, increase trust, and brings a wide range of understanding about the patient population being served that may not be available for people serving patients outside of their general population. If this is something you're interested in learning more about, there's a really great study done on surgery patients in California, where patients treated by a racially or ethnically concordant surgeon had lower levels of readmission and shorter stays in the hospital. And I linked that here. The slides will be shared after the presentation if you want to check that out. So after developing the strategy, we came up with some resources to help with field staff implementation and then implementation in the provider office. The first tool we used in developing the strategy and then implementing the field was this county-specific vaccination coverage report. And this data was pulled from North Carolina's immunization registry. It breaks down for each county vaccination coverage based on race and ethnicity. And each of these reports shows the state and county level coverage with data that you're able to compare. Obviously, in a perfect world, we would love to have these on each of the practice levels to really dive in and break down the population that each office is seeing. Last year, North Carolina was able to add this for each health department. We are definitely headed in that direction. If that information isn't available to you with what you have, AIM releases some state-level vaccination coverage reports with each antigen that compares to your national level. The State Health Access Data Assistance Center, which is shown at the bottom here, does do some breakdown of race and ethnicity status by state. Find something. There's lots of information out there that can be used to judge what's going on in your state. The second item we made for North Carolina was this vaccine toolkit, and I would be happy to share any of the resources here. The first thing it gives you is a GIS map that really breaks down social determinants by each region in North Carolina, to kind of give you an idea and help you visualize in your county what you're seeing. There's some vaccine educational materials from the Association of Immunization Managers in CDC. North Carolina has a historically marginalized toolkit that we're able to link. We have slide decks made specifically for this project. And then at the end, we added some social determinants of health screening guides and resource lists for providers who may need that. This resource guide is shared with providers at each iQuip visit. So during each quality improvement visit, they receive this information to ensure that they have it to train their staff and to implement this strategy effectively in their office. When I was preparing for this presentation, I did a quick Google search to see what was available, and there is a lot of similar information for other states. This is my pride and joy. This is the main slide deck that we share during the iQuip visits. This is the Equity Toolkit deck. The purpose of this deck is for staff education within the clinic. We initially, as field staff, review this during our iQuip visits with the immunization champion, provider, whoever is attending that initial quality improvement visit. And then it's shared within the office for additional education in that level setting that we talked about at the beginning. This is some screen grabs from that GIS social determinants map by region. On the top right there, you have the median household income in Western North Carolina, Northwestern North Carolina. So Forsyth County, Surrey, Stokes, all of that. We have employment in that same region. And at the bottom here, you have percent rent occupied households in Forsyth County. And you can see in the center there, it gets darker as we get towards the more urban area of North Carolina, Forsyth County. Here's some examples of educational materials that we link. We have the videos from CDC, Marginalized Population Toolkit that was updated in 2021. This goes through health equity in general, training resources, communication toolkit, and other items for engagement. The health equity videos from CDC are a great way to share basic health equity information and start that staff training. The podcast series from AIM over here is through organizations that have engaged community partners and the successes that resulted from that. There's some examples from North Carolina, rural Alabama, New York State, and a handful of others. I want to say there's 8 or 9 episodes. I would highly recommend listening to them. And then here's an example of that social determinants of health screening. We can see those first 9 questions address basic needs and gaps the patient may have encountered. And then those last 2 optional questions discuss the urgency of these needs. So you may be able to get this in your EMR system to have that screen-in built into check-in questions or rooming. But if it's not something available in EMR, you have this option to print or use this resource on the computer. Here are some examples of options of where to find resources. Newborn One could work in just about any state. It's usually a website or a phone number you can call to get help with resources. But really the best option I've found is to just Google your county, your state, and the words resource guide. Generally, the school district, the health department, the state work group have something put out there for the county that has a pretty comprehensive list of everything available to patients that you're seeing. So to wrap it up, after talking about all the available resources and how to implement this equity strategy in the practice, I wanted to highlight a couple of things. We've seen a really significant interest in North Carolina from VFC providers that has resulted in a really high demand for that local level equity data, which allows you all as the providers to better understand your specific populations. We also had really great interest from our stakeholders, partner organizations that want to work with us to address these health equity gaps. And because of all this, North Carolina DHHS and our EPI section have continued to have this as a high priority item that we want to work on. Ran through that pretty quickly, but this is my contact information if you have any questions. And I'm going to jump to look at questions if I can.
Yes.
Are there any questions in the chat?
We do have time for questions. So if anybody has questions, feel free to put them in. We'll give it a few minutes to see if anybody has any questions. But while people are thinking, Rachel mentioned this, I just want to say this, that this webinar is recorded and the slides and the recording will be sent to you via the email you used at registration in the next few days. So just keep an eye out for that. You're welcome to share that with your team, or if you have a teammate that couldn't come today, you're welcome to share that.
Please do. Yeah.
Oh, someone just said, perfect. That was my question. Awesome, Jessica. I'm glad I was able to answer that.
That's an easy question, Jessica.
Okay. Yes. If you have any follow-up questions, feel free to email Rachel. And I also wanted to let you know that after this webinar ends, there will be a survey. So please fill us out to give us feedback about what type of webinars you would like to see in 2026. We want to offer you great educational resources that are relevant. So please let us know. And then lastly, if you would like to learn more about us at Patagonia Health, we are an integrated EHR practice management and billing solution designed specifically for public health departments. Thank you so much, Rachel, for coming on today and sharing your expertise. We really appreciate it.
Thank you so much. Thanks everyone for joining us.
Have a great day, everyone.